This is BrainSTEM with your host, neuroscientist Dr. Hilary Marusak, production by Amanpreet Manmeet Bhogal. All right, Johnny, thank you so much for joining us today. I was very excited that you accepted my invitation to come speak. I saw you speak at a conference recently, and I was just blown away by your message. I do want you to introduce yourself in a moment, but you just have such a powerful message and background, from heavy metal and hardcore music to being a really outstanding advocate for mental health awareness and also suicide prevention. So first, can you just tell us a little bit about yourself and tell us how you got to where you are today?
Yeah, this is always hard to sum up, but I guess the shortest version I can think of is I grew up with a bunch of different mental health diagnoses in a home that was pretty unsafe. And I wound up going to school for psychology and working in the peer support space because I not only wanted to learn about what the heck was happening inside of my own brain, but also see if I could help other people. And through that work, doing public advocacy and peer support, I wound up starting to try to create mental health resources. So I made a couple that didn't stand the test of time. And then Cope Notes was my third attempt. And I've been running a mental health company called Cope Notes for about 4.5 years now.
Awesome. And can you tell us a little bit about what Cope Notes does and what are the goals?
Yeah. So a simple way to think about it is we send daily text messages at random times that are written by peers with lived experience and contain, psychology facts or journaling prompts, exercises. And over time, those randomly timed interruptions train your brain to think in healthier patterns.
That's awesome. And we will link to that in the bio of the podcast. I could probably have you on this show for about 10 different episodes, so it was a little bit hard to nail down a specific topic. But this episode today is all about OCD, or obsessive compulsive disorder. So let's get a little bit into that. And we've all heard, the expression, I'm so OCD. It's often portrayed in the media like it's something funny or quirky or even entertaining. We'll get into some of the misconceptions about that later, but can you first start by just describing what it is like for you?
So there's two components, I think, the obsessive part and the compulsive part. So I've always broken that down to look like obsessive might be intrusive thoughts that I'm not actively trying to think. So, something for me might be, I know for a long time, I was very convinced that if I stepped on a crack, that there was like a tiny blade underneath the crack. I mean, just like a crack in the sidewalk or something. I was convinced that there was a tiny blade that no one else could see, that when I stepped on it, it would hurt my foot. It would cut through my shoe and hurt my foot. So that was the obsessive part, is always thinking about not stepping on the cracks. The compulsion part was me literally not stepping on cracks as a result. So I think a lot of my behaviors, my OCD behaviors, could be broken down into the intrusive thought that then drives an action. So the obsession that then drives my compulsion.
Mm-hmm. That's a really good way of describing it too, that there's really thoughts and then you have some sort of action to really avoid yourself from getting kind of anxious about not doing that behavior. Is that correct?
Yeah, in a weird way, it's funny because at the time, I think I would term it control. Like, oh, I'm not stepping on cracks. And this is also just one facet of like, I had a million different ways this manifested. So I don't want people to think like, oh, that's OCD, is like not stepping on cracks. No, there's all sorts of different shapes it can take. But for me, I thought if I don't step on this crack, then that's me taking control. That's me avoiding that pain or avoiding that discomfort, and I'm in control. But actually, looking back, my OCD, my obsessions were actually in control because they were driving my behavior, not Johnny Crowder.
Mm-hmm. Yeah. And when did you first start to notice these types of symptoms? Have they kind of always been there?
Yeah, I think they became most disruptive by 6th grade because that's when they began to affect my relationships with other people, like me socially. I think before then, you know, I was definitely a very quirky and particular child, but I was still fairly capable of like forming interpersonal relationships that weren't so adversely affected by my OCD that I caused issues within them. And probably about sixth grade is when it really started interfering with my daily life to the point where I was not capable of doing a lot of things that, like, quote, regular people were able to do on a daily basis. But I don't even think at the time I would have considered them OCD symptoms. I just thought, the whole world is crazy for not knowing these things that I know. Like, I'm an 11-year-old and I know everything. And I can't believe these adults are like stepping on cracks and touching doorknobs. Like, don't they know what I know? So I kind of thought the whole world is crazy and I'm the only one who's paying attention and is sane enough to recognize it.
Yeah, and can you kind of show us kind of the transition? So obviously you're trained in mental health. You're kind of looking at it from a psychological perspective now. So how is your kind of view of this progressive as you've underwent that training?
Well, when I was first diagnosed, um, so my first reaction was like, oh, I don't have OCD. I definitely was in denial because of that like entertainment component. Like, Monk, the TV show, there was this detective, I think, who has all of these like ways that his OCD manifests in his life. And I would think to myself, like, when I got diagnosed, oh, I don't act like Monk. Like, I don't do those things that I saw on TV. So surely I don't have OCD. And I think when I started taking psychology courses and really studying, I was able to separate my own, this is going to sound sad, but separate my own prejudice against people living with these diagnoses to recognize, like, hey, my textbook is right and my doctors are right. Like, I had this image of people living with mental illness as being like unkind or violent or ill-equipped to form relationships or have a job or be in school or whatever. So when my therapist and my counselors and my doctors would use these terms, these diagnoses, I interpreted them as insults. And I think going through, like, actually pursuing an education in health helped me realize that, like, oh, they're not insulting me. I just have these biases from like movies and TV shows and books that are preventing me from hearing them.
Yeah, and that's so fascinating too, because I think OCD is one of the more like commonly portrayed in movies where it just has that such a strong like stereotype associated with it. So that's really interesting that you went through that own, like, as you were battling through your diagnosis, that own kind of contrast there.
I find it interesting now, like, even I think everybody has prejudice, and the more you learn about something, the less prejudice you become against it because your knowledge base grows from being a very narrow understanding of what something looks like to being more and more broad as you collect more data. So I see my early prejudices against people with mental illness as simply not knowing enough people who live with mental illness. And then slowly, as I met more and more people who live with diagnoses, I'm like, oh, my original idea of what these symptoms manifest as in other people's lives was just so narrow. I was basically only going off of a few examples. But the more people you meet, you're like, wow, sometimes you meet somebody and you have no clue what they're dealing with or going through. And in fact, that's more and more common as I grow up, is like I'm straying away from thinking that I know to being open to the fact that I don't know, and then instead just asking.
That's a really great message too, just simply asking. I'd like to hear a little bit more, if you don't mind, about other types of experiences from other people who you've talked to with OCD, or just kind of the variety of different things that people wouldn't usually think about.
Yeah, one thing that I think is interesting is you hear some of the more common symptoms that you hear of are like, flipping a light switch on and off. for example, or checking if your oven is on multiple times, or things like that, or locking the door multiple times. There are things like that. But actually, have you ever seen the movie The Aviator?
Think so. Maybe a while ago.
So, in my opinion, my personal opinion, that was actually a more accurate portrayal of OCD than I had seen in other films, because there was this intangible nature to how the main character wasn't doing things over and over again to do them. He was doing them until he got it right, quote unquote, until it felt right. So he would, for example, repeat the end of a sentence until it felt like he said it the correct way. And that intangibility, I think, is something that's often lost in media, where like people think, oh, I'm so OCD, I just need to move this painting and now it's perfect. OCD for me felt like it was almost never perfect. Like I would move it and then it was a little too much this way, and I'd move it and it's a little too much this way. And it was that it wasn't like fixing things to make myself feel comfortable. It was that I almost never felt comfortable. And every time I would, quote, fix something, it was an attempt to make myself feel more comfortable, but it was never quite right, because the stimulus was never the problem, because the painting could never be straight enough. You could show me using a level and you could measure out all the angles and show me it's exactly straight. And there's something in me that would say, well, maybe the level is off, and maybe the protractor that they used to measure the angles wasn't correct, or I would somehow make it incorrect. And that to me is like, that's part of the intangibility, and what makes OCD so difficult to describe to people is it's not fixing something to make yourself feel better. It's that almost none of those things would actually make you feel relief, because it will never be perfect enough.
Huh, that's so interesting. I've never heard it described in that way, that you can never kind of get enough data to satisfy, how level the painting is, for example. Very interesting. You covered misconceptions a little bit, but I want to get into that aspect a little bit more, because I think that's really a big issue. And for example, Khloe Kardashian recently claimed to have OCD but she describes it in a very positive light, because it helps her, keep her house clean. And I think, again, everyone thinks about kind of those stereotypical, like hand washing, checking locks. Are there any misconceptions that you'd like to hit on?
Yeah, I actually was doing peer support for a guy who's just about my age, maybe a couple years younger, who lives with severe OCD. And he is, he actually struggles with hygiene. And that, I think a lot of people would say, no, if you're OCD, that means you're always cleaning stuff. And this gentleman was not brushing his teeth, was not taking showers, and hygiene actually became a big issue. And that's not as uncommon as people think. Maybe the socially accepted version of OCD is you like things to be orderly, but it can manifest in all different shapes and sizes. And when I hear things like that, when people say, "Oh, I'm so OCD," I used to be um, pretty triggered by it. I would be like, "You have no freaking idea what I have to live through on a daily basis," and I would make it about me. Like if someone said that they are OCD, I would somehow twist it around and make it about my experience. And as I get older, I kind of realize that when people say that, there are a few options, or there are a few possibilities. One possibility is that they're misusing the term, and that might be because of like very poor health education, or of like most people not really truly understanding the diagnosis in the first place. Or number two could be that maybe they are experiencing real, like diagnosable OCD symptoms, but in a way, in an effort to reduce the stigma, the self stigma that they have upon disclosing this, they kind of share the light and fluffy parts of it so that it doesn't feel so invasive and vulnerable when they're sharing. So, for example, if I share about something related to my OCD, I might say, well, I always wash my hands before I eat. I'm so OCD. And I leave out the fact that I count the number of times that I chew each bite before I swallow. Because to me, part of what I'm disclosing is a little more socially acceptable, and I'm comfortable sharing that on Twitter with my friends and family or something. And then there's part of it that I keep just for me because I have a little bit of shame about it.
Yeah, and shame is a very powerful word. Can you talk a little bit more about that?
I think it ultimately is a product of, have you heard, there's some phrase that I'm probably going to butcher, but I'm sure you've heard it, which is like, um, if you think somebody is normal, you just don't know them very well. And
I've
like,
never heard that, but I love that.
as you get to know them, you're like, wow, this person is really weird and idiosyncratic, and they have all of these things that they want to be a certain way. And I'm in that camp of belief where like everybody has these preferences and tendencies and habits that we just don't really vocalize often for fear of being judged. And I believe that if we all were more open about those things, then each of us would feel less judged. For example, I know for a long time I was afraid to tell people that I lived with schizophrenia and bipolar disorder because those sound really scary. Like anxiety and depression, you might hear like on a Netflix show or something, but schizophrenia and bipolar, it's like, ooh, that somehow feels like a different level. And I think if everybody who lived with those symptoms or diagnoses were more vocal about it, then anytime I did open up, someone would say, oh, yeah, my aunt has bipolar too. Or like, oh, yeah, my cousin lives with schizophrenia. But because we don't talk about it, we don't know. So I think the thing that perpetuates shame is reluctance to disclose, the same way that like the thing that begets darkness is a lack of light. So if we shine light on these things that we're afraid to share, there's progressively less darkness, you know?
Yeah, absolutely. And I think this conversation keeps coming up on this podcast. For example, we did an episode about schizophrenia a couple episodes ago, and stigma was such a huge topic of conversation there for exactly the reasons you brought up. But I think you also brought up an interesting concept of like self stigma, that you had this idea of this diagnosis that, even affected the way that you thought about yourself. So there's just so many layers to it. Do you have any? I mean, obviously, speaking out and being so open about your own experiences really helps kind of shed light. But what can the rest of us do? Kind of follow suit, do the same thing? Do you have any suggestions?
Yeah, I was talking to I was at a fundraiser on Friday, like a mental health fundraiser for a local provider. And this woman next to me was asking, like, what can I do? How do I get involved? And she's like, I'm really passionate about sobriety, and I'm really passionate about suicide prevention. And she had lost a significant other to an intentional overdose. And so she was like, oh, I don't know what organization to organize or to volunteer for. And I'm not sure what, foundation to hit up or where I should get started. And I asked her, like, how vocal are you in your own personal and professional life about sobriety and suicide prevention? And she was like, well, I guess I don't, like, I'm not really talking to anybody about it. And I'm like, you 100%, if you want to go volunteer for organizations, you can do that. And that's a great way to get started. You also don't have to wait for that green light from an organization to start making an impact by simply living out loud, to like make it known amongst your friends and family. And I don't mean to like, write a dossier about your experiences and publish it. I mean, bringing up the fact that you don't drink anymore to one of your friends or family members, or mentioning it casually, or like there are so many ways that we can incorporate this into lifestyle without it having to be like a huge organized coordinated effort. And I think the fallacy is that we wind up waiting so long for the perfect opportunity to make a difference, or to shed that light, or to be an advocate, that we wind up, it's kind of like surfing. You wait and wait for the perfect wave and it never comes, and then you go in and you're like, well, maybe tomorrow. I encourage people to like start locally, so locally that I mean like literally inside of your interpersonal relationships, are there opportunities to bring this up?
Yeah, I love that recommendation too. And I could just see when you were speaking at this event that, you were speaking to public or mental health professionals and, you were speaking so openly about your experiences. So I could just see the audience and they were all connecting with that because everyone has had, an experience personally or a loved one. So I love that of just starting that conversation in a very small way. And it is so weird to me, and it's always been weird that, we think of mental disorders as totally different from biology versus like if you have diabetes, you're not ashamed to say I have diabetes. I go to the doctor, I take,
Hmm.
prescription medications, but why is, diseases of the brain, why are they any different?
Yeah, I also think there's a tendency, specifically with OCD, to miscategorize symptoms as simply being particular or being picky. Like, I know I did that for a long time. Like, if you would have given me, if you would have asked me, um, when I was in high school, do you live with OCD? I would say, no, no way. I don't walk downstairs. I don't touch my food. I don't touch other people. I don't touch doorknobs. I don't sit near windows. I don't step on cracks. And I give you a whole, I count my Cheerios every time I eat them. I could tell you a million different things that I did, but I would justify them as saying, well, I just like things a certain way. And I think that leaves a lot of OCD to go undiagnosed for a long time and people not to get the care and support that they would benefit from simply because there's a tendency. It's almost easier to explain away OCD than it is, for example, like my hallucinations were a little bit harder for me to justify as not being a mental health concern. Um, but me waiting to go to sleep until the clock was at a certain time where all of the digits added up to a good number. I could do that every single night for my entire life, never tell anybody, and just figure, well, that's the way I like going to sleep.
Yeah, that's so interesting too, and the way you kind of justify it, like I'm just particular, but I think a lot of people, can relate to that, so it's a good way of explaining it, but maybe that prevents them from getting the care they actually need. So I did want to ask you about treatments because you've been kind of alluding to things that have helped you in the past. So what would you recommend? What things have you found helpful for dealing with OCD in particular?
Dude, so first of all, I'm not going to be the first or last guest on the show to recommend like treatment. Like, go see if you have the capacity, if you are capable of going to speak with a therapist or counselor about what you're going through, please, please do that. Even if it's just one time, you don't even have to like it. Just go and please, like, make an appointment and try to do that. But I remember when I went to the therapist that I actually stuck with for a while. So I tried a few therapists, really didn't like them. I mean, like one session in or two sessions in, I was like, no, this is not going to work. But when I found somebody who I was like, okay, I feel like she's listening to me and respects me and doesn't treat me like I'm some freak, like some weirdo, we were walking to her. So I went to her specifically for OCD. And she was going to work on other stuff, but it was like primarily to focus on the OCD. And so we're walking down the skinny little hallway to her office, and we walk past this bathroom. And it was like the bathroom for everybody. It was like the public bathroom, just one stall. It was like, or like a one person bathroom. There's no stall. It's just like one toilet. And the door was open. And she motioned over to the bathroom and was like, when I'm done with you, you'll be dunking biscuits in the toilet. And I said, I will never, ever, ever in my entire life do that. I never want to do that. And I got so like riled up. But then I realized the genius in her making these ridiculous comparisons to what I was going through is like we spent the first 3 months on a task which was literally her holding my iPod. That's kind of dating me a little bit. Holding my big brick iPod in her hand for 15 seconds. And then it could be on the table for 2 minutes. And then I had to hold it for 15 seconds. And it felt like the skin was like burning off of my hand. I was like, because it felt almost like I was touching her hand through the iPod. But in comparison, that toilet thing, I was like, well, at least I'm not having to do that. So it made our tasks in treatment surmountable. But my encouragement is like, please, best case scenario, please see a professional and just ask them, share your symptoms and just ask them for their opinion, like what they think. The second thing I encourage you to do, and this isn't always great advice, but please Google it. There are so many people out there in the world who live with similar symptoms. And if you think that you're the only person who doesn't step on cracks or the only person who, doesn't touch doorknobs or whatever, Google that symptom and read on forums and websites and social media. You'll see other people talking about that symptom and the peace that that will give you. I'm not saying look to these people for advice because I don't know their qualifications or anything, but simply seeing proof that other people are living with the same symptoms makes it feel so much more surmountable and makes you feel like you're not being singled out by God to experience this hardship, but instead you're part of a group of people who are facing this challenge. And it just makes it feel makes you feel less isolated and more capable of overcoming.
More in a community. That makes total sense. And I was just thinking too of things like social media and TikTok even. And this is kind of random, but I was on TikTok the other day. My students always laugh at me because we just got the lab on TikTok. But there was a guy who was on there who was recently diagnosed with intestinal failure. And he was just educating people about what that means and what medications he has to take. And I see a lot of that coming up in terms of mental health. And I think there's just so many resources now to connect with people and see what they're experiencing and sharing your own experiences. So I love that. I love that message.
I think it's, especially with OCD, it's the type of thing where you can think, I'm the only person who's experiencing this particular symptom, this particular manifestation of my OCD. And my encouragement to you is you are special, but you are not that special. You're not so special that you're the only person in the history of the universe who's faced this shade of OCD. I would be willing, maybe not my life savings, but I'd be willing to bet a cup of coffee that there's somebody out there in the world who can at least identify with some version of the symptom that you think is only yours. And once you have proof that somebody gets it, this is why I'm such a big proponent of peer support. Once you realize that, it makes it feel like you really can get a handle on it. And I'm kind of, I don't want to survivorship bias this conversation, but I am at least one person in the world who has a much more livable life now because of treatment helping me manage these symptoms.
There you go, folks. Wow. I kind of want to wrap it up there, but I just want to give you an opportunity to talk about where folks can find you, anything else, where folks can find help. And I do want to say very quickly that with things going online due to the pandemic, like psychotherapy is very easily accessible now. Psychology Today has a wonderful website that we will link to that you can find therapists that do online therapy. They're in your area. They specialize in things like OCD, so highly recommend it. But I want to give you the last word. Where can folks find you? What other things do you suggest for folks who are struggling or want to do more to help on this issue?
So you can find me online. Obviously, I think most people, you can find them online. So I have so copenotes.com is where you can find all of the Cope Notes information. You can also try it for free. I also gave 2 TED Talks about mental health. So if you're a nerd like me and you like listening to TED Talks, you can go to YouTube and type in Johnny Crowder and find both of my talks. And I think I just want to say this, if you're the type of person who will spend a half hour listening to a conversation about OCD and mental health like you just did, you're already engaging with health education to a far greater extent than most people you know. Like you're already in the top 10% of people devoting their time and energy to learning about this simply by listening to this podcast in the first place. So I want to encourage people, like, it's not like you have to go get a degree in this stuff. You're literally already doing the thing that is helping you by listening to this, and just don't stop. Like, don't let this be the last episode. Don't let this be the only podcast you listen to. Don't let this not beget more curiosity inside of you and a willingness to learn something new, because that education, that information that you learn by engaging with content like this is your greatest asset in recovery.
Awesome. Thank you, Johnny. I was just smiling because that was so nice. Thank you. We appreciate your time very much, and I'm excited to see what you do next.
Thank you for having me.
All right, Dr. Pittenger, thank you so much for joining us today. For those tuning in on video, he's got a really nice outdoor setting that I'm very jealous about. So shout out, go look at the video version of this podcast on Spotify and on our website and all those places. But we just heard from Johnny, who talked about his personal experience with OCD. And now I'd love to hear from you. We have the real pleasure of speaking with someone who not only studies, but also treats OCD. So can you first just start out by describing OCD? What types of symptoms do people show? How is OCD diagnosed?
Sure. So my name's Chris Pittenger, and I'm the director of the OCD research program at Yale, where, as Hilary said, we do both study OCD, try to better understand where it comes from, but also try to treat people both with standard treatments that we know work pretty well for a lot of people. And then because they don't work well enough for everyone, we do some research to try to discover new ways to treat the condition. So what is OCD? Well, you just heard about it firsthand from an expert. But from a broad, something about OCD is that it can be quite different in different people. It can manifest quite distinctly. What makes OCD different from other psychiatric conditions or other diagnoses is the obsessions and the compulsions. Hardly a surprise given the name of the condition, but obsessions are thoughts that come into the mind that are unbidden, somehow feel unwanted or foreign, not as though they were coming from outside the self. People with OCD, they know they're coming from their own brain, but they seem unwanted and uncomfortable in some way. Now, it's important to realize that having thoughts like that is totally normal. Psychologists have done surveys where they've asked people, do you get thoughts that come unbidden into your mind that feel uncomfortable and you wish you weren't having them? And 90% of people say yes. And I'm pretty sure the other 10% are lying. I think that this is a universal about human thought. So these things only become obsessions when they become powerful and are treated as important and begin to really control people's experience and their actions. And the way they control people's actions is through the compulsions. So the compulsions are behaviors that people engage in order to manage or neutralize or deal with the discomfort that comes from the obsessions. So a very easy one to imagine is a concern about contamination. So feeling that if you touch something, you feel contaminated. What if I have dirt on my hands? What if I have COVID on my hands? Whatever. There's nothing odd about that thought, right? And there's certainly contexts in which it completely normal and appropriate. So then what do? You wash, right? You wash your hands, or you wipe them off on your pants, whatever it may be. Again, completely normal and appropriate. The problem comes when it becomes too much, too powerful, when the thought keeps coming back over and over and over again. And because the thought keeps coming back, you keep engaging in the compulsion, in the behavior over and over and over again. And if you don't, your anxiety goes through the roof. So it's taking these completely normal thoughts, completely normal responses, and turning them up, by a factor of 11. And then unfortunately, when you get that thought in your mind, and then you engage in a behavior to manage it, every time you do that, it makes the thought stronger. Because basically you're treating that thought as though it's powerful and important, and you need to stop everything else to deal with it. And by treating it as important, you make it important. So people with OCD get stuck in this cycle of completely normal thoughts, completely reasonable behaviors that feed back and you get stuck. So that's what OCD is. Mm-hmm. And I gave the example of contamination, but it can be anything. It doesn't have to be dirt and contamination. And that is why Two people with OCD can have rather different symptoms. The most common ones are dirt and contamination and washing, or intrusive fears of bad things happening or harm. And that can be either harm coming to me, harm coming to someone I love, or me causing harm. It can be any of the above. And again, thoughts, worries about that, not unusual. That's just part of the human experience. But if you get then stuck in the cycle where the behavior might be double checking on something, asking for reassurance, making sure everything's okay over and over again. So that's common. The third most common one is a feeling that things need to be symmetric or balanced or just right, or else you feel really uncomfortable. That's usually not a fear that something bad will happen. It's just sort of an incoherent sense that things are wrong or off. And then the compulsion based on aligning things up in order.
Mm-hmm.
So those three groups together, about 70% of OCD, but it can take on other forms as well. It can be quite heterogeneous, quite protean.
Got it. Yeah. And when you were describing kind of the anxiety related components, I know anxiety is a very closely related disorder, and OCD used to be considered one of the anxiety disorders, correct?
Yeah, in DSM-4, it was back, which was 1994. It was called an anxiety disorder. DSM-5 in 2013, they pulled it out to its own cluster in recognition of the ways that it's related to other anxiety disorders, but it's importantly distinct.
Mm-hmm. Yeah, and for those who don't know, the DSM-5 is the Diagnostical and Statistical Manual, basically how psychiatrists diagnose and treat mental disorders.
Yeah.
So I have to ask, have you seen an increase in contamination-related obsessions and compulsions since COVID?
Yeah, it's an interesting question. I think there's several things that have happened in COVID. Early on, so yes, I mean, definitely some people who had, subclinical or mild OCD, COVID kind of pushed them over the edge. Some people who had significant OCD, but they kind of figured out a way to manage their lives and to function very well despite it, got everything disrupted. Interestingly, early in the pandemic, some people with OCD felt better because they kind of felt like the world had come to them. They were always worried about contamination or double checking or the dreadful things may happen. And then suddenly everyone around them was too. And some people told me they felt like they'd been practicing this for their whole life. Now, I only heard that early in the pandemic. As things dragged on, I don't think that persisted. But it was an interesting early reaction.
Absolutely. And how common is OCD, and when do you typically start to see symptoms begin?
Sure. So OCD, I mean, the numbers are, it's about 1 person in 80 in any given year and 1 person in 40 over the course of a lifetime. So it's fairly common that those numbers come from a big epidemiological study. So they're pretty solid. But remember I said that these thoughts are common, and having a relationship between the thoughts and the behaviors that sometimes gets in your way, that's common. So subclinical OCD is much more common. I told you that 90% of people will admit that they have these thoughts sometimes. 28% of people, about 1 person in 4, will say, sometimes they really do bother me and they really get in my way. So this, 2.5%, which is the lifetime prevalence, that's where it's severe enough to really be a problem. But to have it, present enough that you wish it wasn't there, that's about 1 person in 4.
Oh, okay. Yeah. Yeah, and I think a lot of people will connect with that, especially if they do things like meditation, where really that's the practice of identifying those thoughts that come up. So you're right. I think that 10% or so are lying a little bit.
Yeah.
How do you recognize OCD in children, and how does that differ from maybe an adult?
Yeah, that's an interesting question. So it can be tricky. And the reason it can be tricky, when I defined obsessions and compulsions are the thoughts, compulsions are the behavior, right? But there's a relationship between them. And children will often be doing a behavior that seems like a classic OCD behavior, like washing their hands 50 times a day, or double checking that the window's closed 50 times. Double checking once, maybe twice, fine. Doing it 50 times a day, so it becomes, a huge source of anxiety and disruption. You start to think there's OCD there. Children, especially younger children, often can't tell you why they're doing it. They can't tell you, oh yeah, I'm doing that because I have this fear that if I leave the window open, a burglar will come in and hurt mommy. That which might be the motivating fear, but they often can't tell you that. And so we don't know in those cases if that's because the child actually isn't having that thought, if the behavior comes first, or if it's because of difficulty with, psychological mindedness, or, the child just not able to realize that, or not able to verbalize it because they're a child. So it can be a little trickier. And you do see repetitive behaviors in other conditions. I mean, you see repetitive behaviors in autism. You see repetitive behaviors, specific repetitive behaviors in like trichotillomania, where people pull at their hair, excoriation, where they scratch at their skin. So just the fact that a behavior is repetitive doesn't make it automatically a compulsion. So that can be tricky. Classic cases like double checking the window or washing the hands, we're pretty likely to conclude that's OCD.
Mm-hmm. And how does it differ from other neurodevelopmental disorders? You mentioned some already. We talked about anxiety, which we hope to cover soon in a future future episode. But we also touched on things like Tourette syndrome earlier on. So how does OCD relate to those other disorders?
So OCD and Tourette's have a unique relationship. They have a genetic relationship. They run together in families. They have a relationship in what circuits in the brain are impacted. About 30% to 40% of children with Tourette's will develop OCD later in life. You may have talked about, if you did this in the previous podcast, how tics and Tourette's usually get better. About 3 times and 3/4 of the time, they get better over the course of autism. 3/4 of the time, they get better over the course of adolescence, what I meant to say. And but then some significant fraction, like I said, 30 or 40% of the time, OCD then comes on later. So there seems to be a relationship there. There are probably 2 different kinds of OCD: OCD that comes out of tics and OCD that doesn't. But we don't know enough about that yet to be able to call those different diagnoses, or to be able to say with confidence how they're different. But they are related in that way. Tics are often caused by a sensation, a physical discomfort, kind of like the tickle in the back of your nose before you sneeze, where you have a sensation that makes the sneeze feel almost inevitable, almost uncontrollable, but you do have some ability to control it with willpower. Tics kind of the same way. There's a sense of tension or discomfort that needs to be discharged, and the tic discharges it. So that's kind of similar to the relationship between an obsession and a compulsion, right? The obsession is a thought, comes with some anxiety or discomfort, which the compulsion helps to control. So there's some similarities there, but they're not exactly the same thing. The brain abnormalities, which are not physical abnormalities, but in brain activity, we can detect some abnormalities in people with OCD and Tourette's. They're not the same between the 2 disorders. And the treatment is not the same between the 2 disorders. They're related, but they're not identical.
Mm-hmm. Yeah, and we'll get into some of the neurobiology in a moment, but you kind of hinted at the fact that a lot of these disorders, we needed a better microscope to be able to see kind of what is happening. They're not structural or like physical abnormalities. A lot of them are in what you said, like how the brain functions, how it's wired, how different brain areas communicate. So very interesting. But you didn't mention treatment, so I wanted to get into what the current treatments are for OCD.
Sure. So the first-line treatment is either cognitive behavioral therapy of a very specific kind, and I'm going to get to that, or medication with the selective serotonin reuptake inhibitors, which are a particular class of antidepressant medication. They were developed for depression, but they're also useful for OCD. So, and both of those can work quite well. They can both be first-line treatments. Some people are sort of more inclined towards trying the therapy first. Other people are more inclined towards trying the meds first, but they can both be first-line treatments. So the medication, the medications, the antidepressants called selective serotonin reuptake inhibitors, or SSRIs, work fairly well for OCD about 50% of the time. And if you try a couple different agents, you crank the dose up, you can get that up to maybe 60% of the time. You'll have not symptoms will go away completely, but they'll be improved enough to make a significant difference in someone's life, about 60% of the time. Other antidepressants don't work as well. Not everyone has been looked at, but the SNRIs, serotonin norepinephrine reuptake inhibitors like Effexor, don't work as well. Mirtazapine doesn't, Wellbutrin, they don't work as well. Something specific about these serotonergic antidepressants. There are 6 of them in the United States. They're Prozac, Zoloft, Luvox, Celexa, Lexapro, and Paxil. Those are the 6 SSRIs. They all work about the same for OCD. One may work a little better for one person, a different one may work a little better for a different person. They have somewhat different side effects. So the choice is one about convenience and side effects. They all work about the same for OCD. There's also an older medication called clomipramine or anafranil. It also works for OCD, maybe even works a little better than the SSRIs for some people, but it also has more side effects. And so we tend not to use that first. We tend to come to that if a first try hasn't worked. And then if the SSRIs don't work, there's a whole lot. There are other things. You can try a second drug. You can play games with the doses. There are various things that you can do. And that's where we're doing a lot of our research to try to come up with new tools when the SSRIs don't work. Mm-hmm. The other side is cognitive behavioral therapy. It's a specific kind of cognitive behavioral therapy that's been proven to work quite well, and it necessarily involves extinction. The technique's called symptom evocation and response prevention, or ERP. And the basic idea is this. I told you that people get an obsession, of an uncomfortable thought in their mind, and that drives a compulsion, but then engaging in the compulsion makes the thought stronger. You get stuck in a feedback loop. So ERP is basically a way of trying to interrupt that feedback loop. And what you do is this. You induce an obsession. So if someone has contamination concerns, you have them touch something that might be dirty, and then they get anxious, they want to wash their hands. But you don't let them wash their hands. And the person now, or there are other things people can do to try to control their anxiety. They can ask for reassurance. They can symbolically wash their hands. They can try to distract themselves by talking about something else. These are all ways to try to control the anxiety. So in the therapy, you don't do any of those. You just sit there with the anxiety, which is extraordinarily difficult and quite an unnatural thing to do. When you do it, what happens? The anxiety gets worse. And then you start to have what I call second order or meta anxiety, where you start to worry that the anxiety is going to keep getting worse forever, right? And then your head's going to explode. And you just sit there with it. Again, very difficult to do. And then what happens is it goes up. It doesn't go up forever. It plateaus. And then after a while, it comes down without you doing anything. And this is an experience that most people haven't had, because why would you do that? Why would you make yourself uncomfortable and then say that it's like putting your hand on a hot stove and leaving it there when you know that it's an unnatural thing to do. But if you do it and you do it over and over again, what you learn, the first thing you learn, and by learn, I don't mean, I explain it and now you understand. I mean, learn viscerally through practice and through experience. The first thing you learn is that meta anxiety, the fear that it's going to keep going up forever, it's not. That anxiety is not true. It will come back down. That's the first thing you learn. Second thing is you get better at dealing with anxiety, which isn't any fun, but it can help you live your life. But the third thing that happens is the anxiety doesn't go as high. You've gotten used to the exposure. You've gotten used to having the thoughts and just sitting with them, and it doesn't go as, it still goes up, but it doesn't go as high. And then the fourth thing that happens, and the long term and the most important thing, is because you've disrupted the anxiety, you're not engaging in the behaviors, you block this feedback cycle. The loop's not looping anymore. And so the thoughts themselves, the cause of the anxiety, goes away, or at least gets easier to manage, less weak, less strong. So that's how the therapy works. And it's important to know those details and to know the name ERP, because there's a lot of wonderful therapists who are well-versed in cognitive behavioral therapy for panic or for depression who just aren't really good at doing it for OCD. It's a special set of skills, and it's hard. It's hard for the therapist. It's very hard for the patient to go through. But it does work. In some studies, it works as much as 90% of the time. That's with carefully selected patients working with highly expert therapists quite intensively. So in the real world, I'd call it about the same as meds, 50 to 60%. So the two together, we can help a lot of people.
Yeah.
Not everyone, but a lot.
Yeah, and I've never heard it explained in that way. I love that explanation. Very important point, too, to know that there are specific types of therapy. Not all therapists in therapy itself is created equal. So you really want to have someone with that evidence-based background for that specific disorder. And you also highlighted that we have a lot of room for improvement. So if up to half some cases aren't responding, aren't getting better, that leaves a huge gap in a lot of patients who are not getting the relief that they need, which is where your research comes in. So I want to give you an opportunity to go a little bit into what we know about the brain, OCD, what that looks like in the brain, and then how we can use that to really optimize and improve treatments.
Sure. Yeah, that's really a focus of a lot of our work. It's not all testing new treatments, but it's all trying to understand so that we can develop new treatment. We know quite a lot about what's going on in the brain of people with OCD at the circuit level. We know very little about what's going on at the genetic, cellular, and molecular level. which is interesting. That's kind of the opposite of some other conditions. We know it's partially genetic, but we don't know the genes yet. What we do know is early, and this goes way back, early in the days when the technology first became available to do functional imaging of the brain, to image brain activity. One of the very first, if not the first, psychiatric disorder where that was done, and they actually found an area of the brain that was hyperactive, that was abnormally active in patients, was OCD. This was done by Louis Baxter and his colleagues going back to the 1980s, which is the stone age of neuroimaging. They used this originally. They did this with PET imaging. We and others have followed up on it with fMRI and other imaging techniques. But there's a specific circuit, the specific collection of structures in the brain which are hyperactive in OCD. There's the orbitofrontal cortex, which is the cortex sitting right above the eyeballs, right here. Then there's the anterior cingulate cortex, which is kind of in the middle of the brain. And then there are these deep structures that you can't see from the outside. We call them the basal ganglia, the caudate, the putamen, and the thalamus. All of these structures are hyperactive in people with OCD when they're just lying there doing nothing. And they become more hyperactive when symptoms become worse, when you trigger symptoms. This was done in an early study. They got people with OCD, they had them lie in a PET scanner. And then they gave them a wet towel. And they said this was someone's sweaty gym towel. Oh. And that, as you can imagine, that significantly worsened their symptoms. And they were able to see what that did in the brain. So not a nice manipulation, but a very effective one in that study. I don't think it was actually a sweaty gym towel. It was just a little bit wet, but I don't know. I wasn't in the study. That's what I'm hoping. Anyway, so we know these structures are hyperactive. And interestingly, those structures are connected together in a loop. The cortex, the frontal cortex, projects to the basal ganglia, projects to the thalamus, projects back to the cortex. So there's this idea, going back 30 years now, but there's this idea that this feedback loop, just like there's a feedback loop in the behavior and the symptoms, there's a feedback loop in the brain that's hyperactive. And when symptoms get better, that hyperactivity goes down. So we're pretty sure that it matters. It's just not just a random observation. It's actually tied up with the symptoms. So one way to think about treatment is, so we know if we treat people with SSRI antidepressants that symptoms will get better and the hyperactivity in these structures will get better. So one way to think about treatment is, can we directly manipulate those brain regions? Can we do something that isn't a drug at all, but is actually a way of targeting the brain? And so there are people doing that with transcranial magnetic stimulation, which is a way of trying to zap different parts of the brain using magnetic fields. We did an interesting study where we used what's called transcranial direct current stimulation, which is a very low level of electricity passing through the brain, like the amount that you have in a 9-volt battery. And passing it through the orbitofrontal cortex, this part up here that I talked about that's hyperactive, and then doing therapy. It turns out therapy works better if you sort of prime the brain with a low level of electricity first. We just did a sort of a proof of concept that can work. Now we want to grow that out into an actual study to see if we can make it work in people. We have another set of studies where we're trying to do a similar thing, but instead of with stimulation, we're using biofeedback. So biofeedback is when I show you something about your body, or in this case, about your brain, that you normally wouldn't know. And I ask you to see if you can learn with practice, with feedback, to control it. It turns out if I show you the activity of your orbitofrontal cortex, with enough practice, you can learn to control it, which still I think is incredible. I mean, just the fact that the brain can do that, I think, is amazing. And it turns out when we do that, people get better. Their symptoms improve. The effect is small. We want to figure out ways to make it bigger, to see if we can turn that into a real treatment. So that's one line of research. Another is we're looking at new kinds of medication. I told you all the medications that are used are based on serotonin. We're looking at medications that modulate a different neurotransmitter in the brain called glutamate. Why we're looking at that is like a 45-minute lecture, so I won't bore you. But we got interested in the idea that glutamate modulating medications might help in OCD. So we started trying about 20 years ago, and actually there's one that looks pretty good, and we're now doing a large study with a drug company to see if we can develop a new medication to help people who the SSRIs, who the antidepressants like Prozac and Zoloft don't help. See if a different type of medicine could be helpful.
Yeah, the glutamate stuff is so fascinating because for those who don't know, glutamate is kind of the excitatory neurotransmitter. So you're talking about excessive neural activity in these brain areas in OCD. Well, that makes total sense to kind of work on that system.
Maybe you can tamp it down. Yeah. The last thing I want to mention, the last treatment, we're doing a little bit of psychotherapy treatment. Something you can do when people don't respond is just do a lot more psychotherapy. They're actually inpatient units where you can go and get exposure therapy 8 hours a day for your OCD. So that is something you can do. We're looking at some different psychotherapies that may be effective without going to that extreme. But we're also doing the last med study I'll tell you about. We're doing the first study of the psychedelic drug psilocybin in the treatment of OCD. And that's fundamentally different from a drug like Prozac because you're only using it once. Maybe it'll end up being a few times or every few months. I don't know. But for the research, we're doing it once. So people come in and they stay with us briefly in the hospital. They get the psychedelic once. It gives them a dramatic psychological experience for about 4 hours. And then in some people, the OCD symptoms get better and remain better for days or weeks, some cases months. That's a study that's in progress, so I can't call that proven, but we've had some people who've responded very, very well. So that's another exciting direction of this.
Awesome. We'll have to have you back soon and hear about all these results. I think those are there's so many exciting areas that you just pointed out, but the idea that you can kind of use a targeted medication or something like a psychedelic to prime the brain to better respond to something like therapy, which we know works for a lot of folks. That's very exciting. And also on kind of the brain stimulation front, because you understand or you're beginning to understand the exact brain circuits that are involved in something like OCD, you can have a very targeted treatment versus something like a medication that goes everywhere.
Right. Yeah, that's the idea. And I do wonder about the combination, as you said, that, if we can combine a biologically focused treatment like a medication or brain stimulation with a psychologically focused treatment. And I want to be clear that I think that those are really the same thing. They're both different ways of working with the brain. But, one of them is a pill and one of them is talking. And if we can combine the two to get the best of both worlds, that I think is where we can really make a big difference.
Absolutely. All right. I want to just end with what resources you would suggest for families who are struggling with OCD. They think their child may have these behaviors. What do you recommend?
Yeah, it's important to get to people who have some specialty expertise, especially for therapy, because it can, as I said, there's lots of really, really wonderful therapists, lots of great psychiatrists who just don't have the depth of experience with OCD. The best source, there's actually a wonderful website, the International OCD Foundation, iocdf.org rather, is a really wonderful organization, nonprofit patient advocacy group. And they have a good website, and there's a lot of good content on their website, just facts and information written by experts. And but there's also a find a therapist. You put in your zip code. You can put in your radius, how far around your zip code you want to look, and it'll give you therapists, prescribers, clinics, and also support groups. Support groups can be really powerful for people with OCD. One thing that when I was talking about OCD, I didn't get to, but it's quite important, is people with OCD often have an understanding, even an exquisitely painful understanding, that what they're doing doesn't make sense, that the thoughts, the worries are excessive, that the behaviors are doing more harm than good. They often know this. I call this the curse of insight, because then that leads to the feeling that they know that, I had one person say to me, I feel crazy in a way that crazy people don't. Now, as a psychiatrist, I try never to use the word crazy, but I thought what that patient was getting at was very, very poignant, which is because they knew that washing their hands 400 times a day to the point that they're cracked and bleeding was not helping. And they knew that it might look to an outsider, well, crazy. And yet that knowledge didn't help. They weren't able to stop anyway. Because of that, people with OCD will often hide their symptoms. They often will say, I'm anxious or I'm depressed, even to a therapist, even to a doctor. And so getting to someone who knows the right questions to ask and can try to create an environment of trust where people are willing to share these frankly embarrassing things that they're experiencing and frightening sometimes. That's really important.
And Johnny even mentioned that a lot of folks think that they have they're the only person in the world that does this weird behavior. And he was like, well, if you get on any of these support groups, you will know that you are probably not the only one in the world.
Yeah. Yeah, I think being in a room full of people who get it is really powerful.
Absolutely. Well, thank you so much again for your time. I very much appreciate it and excited to see what you do next.
My pleasure. Good to spend this time with you. Take care.
That wraps up another episode of the BrainSTEM podcast. Thank you so much for listening. Please subscribe and share this with friends and family, and be sure to follow us on social media at BrainSTEM Podcast.